O2 tension, PO2, and decreases O2 saturation, SaO2, manifested as a PO2 of less than or equal to 60 millimeters of mercury when the client is receiving an O2 concentration greater than or equal to 60%. Note, room air is 21%. Inadequate oxygen saturation. Inadequate oxygen saturation with supplemental oxygen.
Hypercapnia. Inadequate carbon dioxide removal. Increased carbon dioxide increases arterial CO2 tension, PCO2, manifested as PCO2 of greater than or equal to 45 millimeters of mercury, in combination with a pH less than 7.35. PCO2 higher than normal. Evidence of inability to compensate. pH lowered further will contribute to significant acid-base imbalance. Acute respiratory failure is classified as either hypoxemic or hypercapnic. ARF is not a disease, but rather a condition that results from other causes. In the acute phase, in discussing risk factors and prevention, there are 4 mechanisms that can contribute to ARF. They are ventilation to perfusion mismatch, shunting, either anatomic or intrapulmonary, limited diffusion at the alveolar capillary membrane, and alveolar hypoventilation.
In addition, there are many diseases or conditions that can contribute to the development of ARF.
For hypoxemic ARF, they include ARDS, ARDS of the newborn, pulmonary edema that is cardiogenic, pulmonary embolism, and environmental conditions where too little oxygen is available, such as high altitudes. For hypercapnic ARF, it's COPD, cystic fibrosis, CNS injury such as overdose, chest wall injury such as flail chest, and neuromuscular or spinal cord injury. So what are the signs and symptoms of ARF? The nurse caring for clients at risk must watch them closely for clinical signs of hypoxemia and hypercapnia. Think about clients who aren't circulating adequately oxygenated blood. They might become more and more anxious and develop dyspnea, shallow, rapid respirations, cyanosis, or a dusky appearance of the skin and nail beds. Tachycardia and slightly elevated blood pressure. Or they might be the opposite and have bradycardia and a slight decrease in blood pressure. Now let's picture clients who have too much carbon dioxide in their blood. Typically, they'd report a headache. You'd observe declining mental status. Their skin would appear flushed, warm, and moist, and they'd have high blood pressure and tachycardia. Because clients can present with any variation or level of change, the nurse must also monitor arterial blood gases. ABGs provide an important window through which the nurse can see changes in a client's status that might not be evident on physical assessment. In fact, the primary means of diagnosing acute respiratory failure is ABG analysis. Other diagnostic tools include chest X-ray, CBC, electrolytes, urinalysis, and ECG. If sepsis is a contributing cause, blood and urine cultures might also be ordered. So, what is the goal of treatment for a client with ARF? The goal is adequate oxygenation and ventilation. Therefore, respiratory therapy is essential. That means oxygen supplementation, secretion management, and positive pressure ventilation, plus nursing interventions that promote effective airway clearance, maintenance of normal breathing patterns, normal gas exchange, fluid and electrolyte balance, and nutritional supplementation to meet body requirements. In addition, the client who is this seriously ill and is having breathing problems will experience and manifest signs and symptoms of anxiety. Nursing interventions to reduce the client's anxiety and promote relaxation are crucial. Pharmacotherapy for a client who has ARF includes a bronchodilator to ease bronchospasm. a corticosteroid to reduce airway inflammation, a diuretic to decrease pulmonary edema, an anti-anxiety agent to reduce anxiety, and an antibiotic to treat underlying pulmonary infection, and whatever medications are appropriate for treating any other contributing causes. Now, here's a new consult in the CCU for one of the pulmonologists. This client came in with an acute MI and developed pulmonary edema. They asked the pulmonary physician to manage his lung condition. Let's review what you know about caring for a client who has pulmonary edema. The first thing to remember is that pulmonary edema is very serious and life-threatening. Fluid accumulates within the lung, either in the interstitial spaces or in the alveoli, and decreases the lung space available for oxygen exchange. It is usually cardiac in nature, like with this client, but it can also result from a drug overdose, post-pneumonectomy, or occasionally from a neurological dysfunction. Whatever the cause, remember that pulmonary edema is a medical emergency. We've already talked about some of the risk factors, but do you remember the others? How about hypertension, heart valve disease, sepsis, and fluid overload? You probably remember that last one when you learned to start IVs. Don't overload your client, especially those who are elderly, or you'll increase their risk for CHF and pulmonary edema. Auscultate their heart sounds and assess for an S3, which might indicate CHF. When caring for clients at risk for pulmonary edema, what signs and symptoms would alert you that they are indeed developing it? Restlessness, anxiety, dyspnea, hypoxemia, cough with pink frothy sputum, tachypnea, cyanosis, and a sense of suffocation. Sometimes clients with pulmonary edema appear to swim in their beds. When you do the physical exam, you'll want to pay particular attention to the pulse, which might be weak and rapid. They might also have neck vein distension, an ashen gray color, and confusion. Nurses are such an important part of the care of clients at risk for pulmonary edema. Your careful assessment is the key to identifying the early signs of pulmonary edema.